of the drain.
Okay, drain of the day today. We're just going to talk about fairly simple drains, and nothing complicated like a T-tube or a chest drain or something like that. We're going to go back to the very simplest of drains. And usually when you're in theatre and you open a drain package where you want suction, you'll get something that administers a suction, and then you'll get a piece of tubing that actually acts as the drain. Now the basic tubing that comes with a kit is just a piece of plastic tubing with holes in it. I'll pass that around for you to have a look at. So plastic tubing with holes. And there's a spike on it, so don't stab each other. The spike's there to make a hole in this skin to get the drain out. Now, usually we don't use that. The alternative is a thing called a Jackson-Pratt drain, which also has holes in it, but the holes are a lot smaller. So Jackson-Pratt drain, smaller holes. I'll pass that around. And some of the surgeons use those for different reasons. Most of the general surgeons don't. Most of the general surgeons use this thing called a Blake drain, which doesn't have any holes, has some corrugations, and so the Blake drain doesn't have any holes, and when we're putting in that in the abdominal cavity, what are some of the advantages of not having any holes there? Or perhaps anywhere?
Not suction anything into it.
Yeah, such as, yeah, omentum generally. So certainly the first drain you saw with the big holes, if there was suction applied and you've got bits of omentum in it, you can imagine that when the drain is removed, that it could cause a bit of trauma, have some bleeding inside. So that's why we often use the Blake drain now. If it's got no holes, how does the fluid come out? Tara, any ideas?
I mean, it's still got the hole at the end.
It does have the hole at the end, yeah, but not along the tube.
The pressure difference.
Yeah, pressure difference, and I guess some of that pressure difference is by capillary action of the material and fluid just running along the material. Because even when you've got a fairly high drainage site like a lymph node dissection, or if there's some abdominal fluid, even when you're getting 80 or 100 or even 200 mils of fluid a day, in terms of fluid per hour, if you're getting 120 mils of fluid per day, that's only 5 mils per hour. So you can imagine that you don't really need a tube with lots of big holes in it when you're literally draining 5 mils per hour. So the capillary action, the Blake drain with no holes using capillary action is more than enough to drain that sort of quantity of fluid. Purposes, why do we use these simple drains? What's their purpose? Ali, what do drains do?
If there is a concern about
So what things do we drain?
bile,
Yeah, we can drain bile,
contamination,
yeah,
blood,
pus,
fluids,
blood,
serum.
seroma fluid. Yeah, you can do, you can drain all those things. And I think when you see a drain on the ward, have a think about why it's there. And if you're not sure, feel free to ask the boss why it's there, because it'll be there for different reasons for different patients. Commonly in the ASU, apart from appendicectomy, cholecystectomy is the most common operation. And the main reason why people often put drains in there, with drains there's lots of different thinking, is if it's a simple operation, just to drain any blood or bile that may have leaked from the operation, even though the operation's otherwise gone well, by draining any residual bile or blood that might have leaked during the operation, you increase patient comfort. There's also a certain placebo effect with having a drain there, because if they have pain when you take the drain out on day one, they feel a whole lot better. They think that's wonderful too. So in the simple lap chole, it can just be to keep the area clean to reduce pain. Sometimes also in the past people have thought that by getting helping to evacuate the pneumoperitoneum, that might help too. And then for the more complicated cholecystectomy, we may put a drain in if we think the risk of a bile leak is high. If there's a stone in the common bile duct that's going to increase pressure in the system, the chance of a bile leak, or say the clips on the cystic duct not working, increase. If it's been a particularly difficult operation and there's lots of blood and ooze, then it's reasonable to keep it draining just to keep the operative site clean. In an appendix operation, almost all cases you'll never see a drain, but occasionally if it's been particularly contaminated, one might want to put a drain in to keep that clean. In breast surgery, you see drains put in a lot for the seroma, and the breast surgeons have their magic number of how much needs to come out per day. And that's sometimes as low as 20 mils a day, which is actually sort of less than 1 mil per hour before taking the drain out. And they keep seroma collections down for patient comfort, to reduce the chance of infection, and for those reasons. For some other operations like colorectal procedures, you'll see a drain put in close to anastomosis, rectal anastomosis, and the reason why that drain there is again different between different surgeons. So if you're putting a drain there for bleeding, when do you usually take the drain out? No idea. So unless there's some other reason why they're going to bleed, like they're coagulopathic or they're on therapeutic heparin for a metallic valve or something like that, you shouldn't really bleed after a day. So if you're putting the drain because you're worried about an oozy operative site, and you've got a drain in the pelvis, you can probably take that out after a day. Your second reason for leaving a drain in might be concern about the anastomosis. If that's the reason why you're leaving the drain in, then when might you leave? When do you take the drain out in that situation? Sorry.
Because there's a leak, usually there's a leak happen if it's
Yeah, or perhaps return of bowel function.
bowel function.
So if this bowel function is returned, and you're happy that everything's going smoothly, then you can take out the drain there. And so even in someone who's got a stoma, who's got a drain next to their anastomosis, return of bowel function might be return of function of the stoma. That indicates that things in the gut are working well, and then you might take the drain out at that time. So removing a pelvic drain after colorectal surgery depends on the timing, depends on the indication. If you're not worried about a leak, and if you're just worried about seroma formation in the pelvis, not that I see that as an indication much, then you might leave it in for a between period. Where we've sort of discussed, so obviously after a gallbladder, either in the gallbladder fossa or in the suprahepatic space. Appendix is obviously usually in the pelvis. A colorectal anastomosis in the pelvis. Where else do we put them in the abdomen? I mean, obviously after pancreatic surgery or colorectal surgery, if you're worried about tranging the pancreas, they can be left near the pancreatic bed, and then MLAs can be checked for down the track. After a total thyroidectomy, how good is the drain at evacuating a hematoma? True. So if you've got a patient with a total thyroidectomy, they've got 2 drains coming out, and you're the resident overnight, can you sleep safely and soundly knowing that if they develop the hematoma, you wouldn't have to cut it all open or wall because the drains would evacuate the blood? I'm getting shakes of the head. The residents still wouldn't sleep well. Yeah, that's right. So drains can, and certainly do drain some blood out, but you can't rely on them to drain everything out. Equally in all these situations, drains are great for removing pus and bile and things like that, but they're not perfect, and so you can still get you can still get an infection there that's not reached by the drain. You can still get lots of bleeding from a post-thyroidectomy that's not drained completely. And so if there is significant bleeding post-thyroidectomy, you will still have to get out your knife and cut open the wound as an urgent procedure on the ward. The drains alone won't necessarily evacuate all the blood. And I think in the breast surgeons and the thyroid surgeons also use the Blake drain because it's less traumatic on the tissues. Removing drains. So often those drains are on suction. I might have handed around some of the suction devices. How do you do your suction devices? How do you remove a drain? We've talked about removing a chest drain previously, and that's more about making sure no gas goes into the pleural space when you remove a drain. Is there any particular special consideration for removing one of these drains in the abdomen? Yeah, look, it probably matters more for those suction drains that have the holes in it, because if you've got some momentum stuck in it, reducing the suction means you're less. It's probably less important with a Blake drain, but as a safety thing and as a thing of good practice, you should try to take the drain off suction before you take a drain out. It's not, you don't see it well because I'm canning out the bits and pieces as components, but that's all right. Yeah, you can make some music with it if you want with your accordion. But when it's all connected together, it's a closed system, and the only way to truly take it off suction is to actually cut the tubing. You can play around with all the valves as much as you like, and particularly for that bottom clamp, there is still a valve in the system. So if you left that clamp open, you can push fluid out of it, but air's not going to come in to release the suction. So the only way to truly release the suction is to cut the tube or disconnect the tube. And so most of you won't need to take out a drain because the nursing staff will do it, but that's just one thing to remember. Take it off suction and think about how the drain's set up and convince yourself that suction has been released before you take it out. Any other questions or queries about drains?
In a few of our patients in the past, we've clamped the drain before and seen if it causes pain or anything before taking it out.
Yeah.
When would you do that rather than just decide?
Yeah, so that's a pretty specialised situation. Probably not with any of these simple drains, I don't think. Chest drains, you'll do it, and when they get their pain and tracheal deviation from their tension pneumothorax, you know that there's something wrong and just release it. And the other situation that might have come up recently is, I think a T tube was.
Yeah.
So that's a specialised situation where in that gentleman, in Mr. T, I think it was, he had a T tube in. Should probably draw it the other way. So his gallbladder's cut off and the cystic duct's clamped, and then he's got a T tube that comes out. And then down here, before going into the duodenum, there's still a big rock here, and you saw that every day you're still getting 600 mils bile, which is practically how much bile the liver makes every day, 600 mils. So basically all the bile was coming out here, and none of it was coming down here. And if you clamp the tube, you can imagine that you'd probably get jaundiced again, and the pressure down here would probably cause some pain. So you could use it in that situation as a diagnostic test. But these simple drains, I can't think of an indication where you'd clamp it. But yeah, in some specialised situations, you would clamp it just to see if there is pressure in the system, and obviously pain from that pressure gives you an indication of what's happening. Any other? Yeah.
You also mentioning Blake drains are predominantly what is used in gen surg now.
Yeah.
Are there still situations where we use the older ones?
In my experience, to tell you the truth, I know one of the urologists uses this quite a lot. Yeah, I don't know if there's slightly more drainage in his operations, but yeah, generally all the general surgeons just use the black drain. Anything else? Okay, we'll leave it.